Hospital Zagreb that the cardiovascular diseases are killer number one, the world's number one killer. You can see it here on this slide. And the dyslipidemia, high cholesterol, high lipoprotein delay as well is for sure the cause of it. We all know in the primary prevention, for example, if we have LDL cholesterol, that is in between 50 to 70 milligrams per deciliter. That means 1.4 to 1.8 millimoles per liter. That this is the lower, this is the better, and this is the physiology of normal. Because nowadays the newborn children, some of the tribes that are living in Africa that have the isolated way of life, the old way of life, have such low values of LDL cholesterol. It is not pathophysiologic level, it is physiologic level. Some of the studies showed that when the children are born, they have LDL around 1 millimoles per liter, and they completely normally develop their membranes, their brain, their hormones, and all other things. In primary prevention, there is a study I'm showing you now, more than 20 years ago, that says if all population have LDL cholesterol lower than 1.5 millimoles per liter in primary prevention, the cardiovascular diseases will be non-existent. So for many years, dyslipidemia was viewed mainly through the lens of cardiovascular prevention. We measured LDL cholesterol, we estimated cardiovascular risk, and we treated patients to prevent myocardial infarction and stroke. But today, I would argue that dyslipidemia represents something much broader. It may actually reflect the biology of aging itself. The same mechanism that drive biological aging, oxidative stress, chronic inflammation, insulin resistance, and mitochondrial dysfunction also affect lipid metabolism. So perhaps dyslipidemia is not only a simple laboratory abnormality. Perhaps it is a biological signal. A signal that the vascular and metabolic system is aging, and this idea is especially important today as longevity medicine increasingly moves from theory into the clinical practice. One of the central mechanisms of aging is redistribution of adipose tissue. We are all facing the pandemic of obesity, the visceral obesity. As we age, visceral adiposity progressively increases, and visceral fat is not simply an energy storage organ. It's not only the aesthetic defect. It behaves as an endocrine and inflammatory organ. It secretes cytokines that we then call adipokines, promotes insulin resistance, and contributes to production of atherogenic lipoproteins. At the same time, this chronic low-grade inflammation becomes progressively more pronounced. Oxidative stress accumulates, mitochondrial efficiency declines, and cholesterol metabolism becomes dysregulated. What is fascinating for me is that several pathways traditionally associated with longevity biology are also deeply involved in lipid metabolism. SRAT1 activity decreases, AMPK signaling decreases, mTOR activity decreases, PCSK9 expression may rise, leading to increased LDL receptor degradation and impaired LDL clearance. So, aging gradually shifts the organism toward the pro-atherogenic metabolic state. And I think clinically this matters and manifests as endothelial dysfunction, arterial stiffness, and accelerated vascular aging. There is a recognizable lipid phenotype associated with aging. We typically clinically observe, and we see it in everyday clinical practice, as increase in LDL cholesterol, increase in triglycerides, more small dense LDL particles, dysfunctional HDL, and reduced insulin sensitivity. But importantly, these changes are not isolated. They are part of a systemic biological process. The vascular wall becomes exposed to persistent inflammatory activation and oxidative stress. Endothelial function deteriorates, arterial stiffness progresses, and plaque instability increases. This creates what would call a self-amplifying aging loop. Aging, for sure, promotes dyslipidemia, and dyslipidemia further accelerates vascular aging. I think this is one of the most important concepts in preventive cardiology today, because when we see dyslipidemia in clinical practice, we may actually be observing accelerating biological aging in real time. We have to be aware of it as clinicians. What makes this topic especially interesting is the, I would like to call it, intersection between longevity biology and lipid metabolism. One important pathway involves SIRT1. Experimental studies demonstrated that increased SIRT1 activity was associated with lower LDL cholesterol, improved insulin sensitivity, and reduced atherosclerosis. Another important mechanism involves PCSK9, so a serine protease that we are now as clinicians attacking to lower them to lower LDL cholesterol with monoclonal antibodies or small interfering RNA. We know that reduction of PCSK9 expression improves LDL receptor availability and enhances LDL clearance. This is fascinating because it really connects molecular aging pathways directly with lipid handling. We also know that calorie restriction is another important longevity mechanism. Across multiple experimental models, the calorie restriction has constantly been associated with delayed metabolic aging and lifetime extension. It reduces oxidative stress, inhibits mTOR signaling, and improves metabolic efficiency. Then we have metformin and AMPK activation may produce similar effect. So when we discuss dyslipidemia today, we are no longer discussing only LDL cholesterol. We are discussing nutrient sensing, mitochondrial biology, and aging pathways. The most elegant, I think, proof that vascular and metabolic health matter comes from long-living populations, so-called the blue zones, and we are in media bombarded more and more about the blue zones. These include several regia around the world, for example, Icaria, Okinawa, Sardinia, Nicoya, and Loma Linda, as you can see here, and who would not like to live in such a beautiful place? I think that those sceneries can be seen as well. Is probably Mediterranean in Italy, and I know that those sceneries are also existent in Croatia. So, despite geographical and cultural differences, those populations share several common features: healthier metabolic profiles, preserved vascular elasticity, lower inflammatory burden, and delayed vascular aging. One particular important observation comes from the Icaria study. Pulse wave velocity, a surrogate marker of arterial stiffness, was significantly lower in older inhabitants compared with age-matched populations. This suggests delayed vascular aging for sure, and perhaps this is one of the central messages of longevity medicine. We know, and we tend to say, you are only as old as your arteries. Importantly, these populations also consistently exhibit lifestyle patterns that favor healthy lipid metabolism. Mediterranean diet for sure, lower caloric intake, regular physical activity, and low smoking prevalence. So lifestyle is not only modifying cardiovascular risk, it is modifying the biology of aging itself. And then we can come to Milan. Once again, I'm very sad that I'm not in person now in Milan, but only online in pre-recorded lecture. So you see that this is very, very stressful. It is beautiful, but it is a very, very stressful environment, far away from blue zones. So the lifestyle is here influencing much, much more. And when we are talking about the cholesterol, we cannot expect that those inhabitants, because of the low physical activity, poor eating habits, stress, air pollution has LDL cholesterol, as physically has the tribes that are living in the Africa or in newborn children. Our LDL cholesterol is much, much higher. For example, in Croatia, I will just point that LDL cholesterol higher than 3.0 millimoles per liter have around 65% of Croatian population. So let's go a bit in the past, because 50 years ago the metabolism of LDL receptor and LDL cholesterol was discovered, and those two guys got the Nobel Prize in the physiology in medicine in 1985. After that, the drugs that I will present, and you know those drugs because you're all using them, the clinicians use them, is the statins. And Endo showed here, discovered the statins, and they were called the penicillin of hypercholesterolemia. So we know what the penicillin did for infectious diseases, saved lives, and I am completely assured that hypolipemic drugs, and mainly as a first line of therapy, statins, do save lives. They are efficient and they are safe. But as the story about the efficacy and the safety of the statins from the scientific population was growing, the media, because they tend to write not only the good things but the bad things, because the bad things sell the newspapers and nowadays sells the clicks. They started a quite negative campaign against the hypolipemic drugs or cholesterol lowering drugs, as you can see here. It culminated, as you can see, on the 14th of February 1992, when they stated that the murders are linked to the low-fat drugs. And this was a big problem. This study was heavily biased. The murders among patients that were in this study was not connected to the therapy. But it ended up and had a big repercussion on one big scientific trial from Daiichi Sankyo. They were examining one statin on patients with FH, and this study has to be stopped because of this media, the negative media coverage about the hypolipemic drugs. And just imagine what was the repercussion of this stopping such important statin trial. Nowadays, we know that the statins are effective, that they are safe, and that they for sure save life and prolong life. Nowadays, maybe we do not buy a newspaper, but once again, I says that the negative publicity sells the clicks. This is one of the very famous TikTokers. This is the power of social media. It's a chiropractic from Canada, Dr. Don, and he's pointing the finger. He's talking against the statin therapy. And you probably know this guy because he's also the lecturer here, and I am sending the big hello to him. This is Professor Landsberg, and I think he's the number one clinician and the scientist and the man that is able to talk about the statins. If you are not subscribed to his statin newsletter that he is publishing, please do so and be informed about the efficacy and safety of the statin therapy. So what are the factors that amplify this risk of the statin skepticism? So first of all, we as clinicians are clinically inert. What does it mean, clinical inertia? It means that if you have dyslipidemia and you have a pathological value of LDL cholesterol, you do not intervene. Or if the patient is not in target, you do not increase the dose of the drug, or you do not add-on therapy. If you have a bad communication with the patient, it will all lead to the poor adherence to the statin therapy. And dyslipidemia for sure is a problem, and the statins can help with this problem. So while I was Googling for this presentation and to tell you the story about the efficacy of statin in prolonging life, I was Googling also, and I was typing into the search the statins and the fear of statins and side effects of statins, and it transferred me completely, I would like to say, on the dark side, because after that the meta algorithm caught my search. And while I was preparing these presentations, I asked the artificial intelligence to produce the picture from the outpatient clinic where a physician is prescribing a statin. And this is the picture what artificial intelligence produced me. So as you can see, what is the power of the algorithm and what is the power of the things that we are Googling. You can be brought completely to the dark side and you can be misinformed. Because for sure, we know from the science that the statin can be it's effective and safe drug, and the statins and lowering of the LDL cholesterol means longevity. Is the statin the holy grail of our life, of the longevity? I think it is. So once again, what to do to increase the awareness, or as we can say, the health literacy about the in danger of dyslipidemia. I will show you how we are doing that in Croatia. We are running one very big public health campaign. It's called the Hunting the Silent Killer. And this is the video that explains to the general population on national television the danger of untreated and undiagnosed dyslipidemia. So please look at this video.
Tata, što radiš ovdje? Tata, što radiš ovdje?
Ne mogu doći večeras.
Oj.
Ne mogu doći večeras. Neću
Oj.
biti više ovdje. Neću biti više ovdje.
Kada ćeš se vratiti? Ne razumijem, tata. Ne razumijem, tata.
Pazi na mamu. Zbogom ja.
Tata.
Zbogom ja.
Tata.
Možeš li doći sam?
Ja.
Možeš li doći sam?
So you have to check your cholesterol, you have to treat your cholesterol, you have to treat your hypertension, you have to treat all your cardio metabolic risk factors. My colleagues will also address that to save your life, to prolong your healthy life. So the most important message from this presentation is that dyslipidemia should not be viewed as only as elevated LDL cholesterol. It reflects the metabolic dysfunction, the inflammatory burden, the vascular aging, endothelial health, and potentially biological age itself. This changes the way we think about prevention. I think perhaps the future of preventive cardiology is not simply aggressive lipid lowering. Perhaps it is a preservation of cardiovascular youth. This requires an integrated approach, as you saw. The lipid management, the increasing of the health literacy about the in danger of the lipids, of the high lipids of dyslipidemia. Also as well the blood pressure control, the glucose regulation, the physical activity, the Mediterranean nutrition, inflammation reduction, and preservation of vascular functions. In other words, longevity medicine and preventive cardiology are, I think, converging. And dyslipidemia sits directly in the center of this intersection, as I said. So I would like to conclude, dear colleagues, with one of the final thoughts. The goal is not simply longer life. The goal is longer, healthy cardiovascular lifespan. Because a lifespan without vascular health is not true longevity. Thank you very much for your attention, and I would like to point that the modern longevity medicine is not magic, it is prevention. And I will gladly answer to all your questions if you have it. I'm not able to connect online now live, but you can post any questions to my email that you can see here at the bottom of your screen. I wish you a very good meeting, and I'm sending you the greetings from Zagreb, from Croatia.